Okay, I think it is working now. All right. So good morning, everyone. Good morning. We're going to push that away. It is my honor to talk to you today about a Pakora Award that Brian Gibson and I worked on for the last 3 years. The topic is community partners as our teachers in the conduct of community-engaged research. Jeanette Villalta was our teacher on the Pakora Tier 3 Award. And here is our team. Now we have some of our team members here, and I wanted to make sure I pointed out Brian, he's right here, and Michelle Lichman. Now Brian, let me back up. He's from the Biomedical Informatics Department, which is part of the School of Medicine. Michelle Lichman is actually in clinic seeing patients. She's from the College of Nursing. Anna Sanchez-Burkhead, she's from the College of Nursing, and she's in Washington, D.C. doing some important work. And then we've got students, Vanessa. There, better stand up. She's a PhD student in the College of Nursing. And Leah Yingling, and she's attending her sister's wedding, but she's a biomedical informatics student. And we've had a research assistant who was an undergraduate RN student, Elisa Amador, who is now a full-fledged RN at the University Hospital. So that was our team on the Tier 3 award, and I'll tell you more about that. So Brian and I, he wrote the Tier 1 award, and we did a Tier 2 and a Tier 3 award. The Tier 1 award, the purpose, now how many of you are familiar with Pakora Awards? Oh, quite a few people actually. So Pakora stands for Patient-Centered Outcomes Research Initiative. And these awards, the first award that you normally get, you're charged with putting together a community advisory board, I mean, depending on the type of research that you're doing. And that's what our charge was. And we then met with Hispanic individuals, and that was the title of our award, Community Partnership for Patient-Centered Outcomes Research in Hispanics with Type 2 Diabetes. And that was the title of all 3 of our awards. And we put together this community advisory board, and we asked them, about their problems that they had in their daily lives with managing Type 2 diabetes. And then we worked on, after we got that list together, what were some of the possible solutions that they could come up with in terms of that would help them with managing their type 2 diabetes. In the Tier 2 award, we then refined that list of problems and solutions, and then we took, and Brian put together a kind of a big survey, and we took it out to the community, and we asked them, to kind of rate what they thought their problems were, and what solutions they thought would best meet their needs. Now, Brian and I are kind of technology people, and so we kind of came up with some technology-driven solutions, and we asked them to kind of rate it, using telephone interventions, mobile phone apps, different things like that. And we had 150 people participate in this survey, so we got quite a bit of community feedback. And then the Tier 3 award, I'll tell you more about. What was happening in our Tier 1 and our Tier 2 award, though, is we had problems getting an active community advisory board. So when we went to write that Tier 3 award, this is one of the things we decided to write into the award, was we needed to really get some help going on our community advisory board. So we wrote into it that Jeanette was going to kind of be our teacher. So she was actually a co-leader on this award. And so we also wrote into the award that we would have a Hispanic nurse researcher with ties to the Hispanic community and expertise in community-based participatory research. We also had a diabetes nurse practitioner with expertise in peer support and social media. And so what Jeanette did was she became our teacher, and she had 10 strategies that she taught us on how to really build this, community advisory board. And I thought that since many of you are working with communities, that we would share with you how we did this. Because today, we still have a very active community advisory board. So the first strategy was to invite a diverse group of healthcare providers and patients to discuss a partnership for conducting a research study. So this is what she did. We kind of pointed out some of the things that we thought we needed to really strengthen this community advisory board. And she went out and she found these people. And this is who she found. She found a community health worker who worked at a free clinic providing diabetes education. And I'm really excited because that person is here. Maria, can you just stand up?
Sure.
Okay. So Maria worked at the Malahi Clinic, and she is, really.
Volunteer.
She volunteered at the community health clinic at the Malahi Clinic, teaching people about diabetes. Now, she was an RN in her country, so not only were they getting amazing expertise from her, but, I'm so pleased to announce that now she's a community health worker for the University of Utah. So she was just hired a couple weeks ago. And she's so happy. So we also, we also had a social worker that Jeanette found who worked in the Hispanic community. And it was fascinating because this social worker was a PhD student here at the University of Utah. So not only did she, know everything about, because she also had a real job in the community, but she also knew quite a bit about research, so we had that advantage. And then we had another individual from the public health department. He understands research very well. He got so excited about doing Pakora research that he attended the regional meeting and then became a Pakora grant reviewer. So another great success story. All of these individuals, once again, were Hispanic individuals with type 2 diabetes. We had a pastor who came to our meetings, and then Jeanette invited several community members. And once again, this is a very active community advisory board. So this is just a picture. This was at Christmas, and there's several people here. Not everybody made it to Christmas, but as you can see, there were many who did. So strategy number 2, before we started the Community Advisory Board for this Tier 3 award, we met as an executive board, with the researchers and our co-lead and some of the key stakeholders. And what we did is we kind of discussed our approach up front. And we, discussed that we were going to explain the purpose of the Pakora Award. I mean, we were good at doing that in Tier 1 and Tier 2, but what Jeanette really helped us with was to make sure that we were working with the health literacy of the community members, and we explained the research concepts in an understandable language. And she was great at helping us with that. We explained the previous work that was accomplished in the Tier 1 and the Tier 2 award. And then what she pointed out to us that was very important was to ask for confirmation of these new Tier 3 awards. Was this the work that they wanted to do? And then we also asked their permission, how best can we solve the needs of the community with this award? And these were important steps at that first meeting. Okay, Jeanette, can you tell them about strategy number 3?
Oh, yes. Hi, everyone. The number 3 strategy was the meeting at a convenience place. When you want to approach the community, you have to go to the community. You don't them to come to you, but you have to go where they gather. And we find the Sun Unity Center is in Salt Lake City, it's in the area of Glendale. Glendale have a population of 38% of Hispanic. We thought it was a perfect place because cultures getting together is a place where cultures are welcome. And when they feel safe, comfortable, they have enough space for parking. They have rooms where large rooms where we can get together. We have all the equipment. It was the perfect place to have the meetings. And it's a safe place, as I said, where community members feel that they can come with knowledge that nothing is going to happen to them, because right now people sometimes is afraid for researchers because they think there's a misunderstanding, a connection between researchers and community. And I think this was the perfect place. And proof is that we have a successful group of 25 people attending every month to the meetings, and the numbers are counting on. Yeah.
Mm-hmm. Strategy number 4, empower everyone to develop the agenda. This can be done through several methods, using Facebook, text messages, and then developing it at each meeting. So it's important that everybody as part of that community advisory board feels their message, that their voices are heard. And there's a lot of ways that you can discourage people from feeling that their voice is heard. You can do it kind of indirectly by, being that researcher that kind of, discredits what they had to say. Or you can sit there and kind of, lay yourself open and tell me what, you have to say. And the other things that we did is we had our agendas in both English and in Spanish. So some people, were more open to wanting things to be in English, and some people were more open to having things in Spanish. We had, when we listened, now I tend to be one of those people who like to get down to business and get things done, right? Time is precious. I'm busy. Well, you know what? That's the wrong attitude to take when you're going into working with a community. So Jeanette taught us. She said, we brought refreshments, and she said, make time for people to gather, to talk. And then she said, as a researcher, you need to also think about giving back to that community. So what they want from you is education. You want from them that research piece, but you need to give to them as well. So that was an important lesson. And then we used Facebook to provide research, education, and social support. Now, I'm going to tell you that Facebook didn't work out so well for us. We used it, but the community didn't really engage like we had hoped they would. It's still there. It's up. We had a lot of different strategies, but it didn't work as well as we'd hoped. But, you try different things, right? Okay, strategy number 5. Okay, this was a great idea that Jeanette brought to us. And it's called World Cafe. We had all these different questions that we were trying to debate. We'd been listening for a couple years about the different problems and the different solutions. And Brian and I, with our heads on and our researcher hats on, we're thinking about ways to solve this. And so we had these 3 different questions. And when in Pakora, you do comparative effectiveness questions. And so we said, okay, we wanted to compare diabetes education that's delivered in the classroom to diabetes education that's delivered using a health coach. And the mechanism was to use phone and, a tablet to provide the diabetes education. We wanted to do Another question was to compare diabetes social support that takes place in a face-to-face group session to diabetes social support that takes place on the internet. And then we were going to look at comparing diabetes education that's delivered in the classroom to diabetes education that's delivered on the mobile phone. Oh, now how do you pick those things? Well, you go to the community, right? And you say, let's figure this out. Well, she brought us this World Cafe idea. So what you do is you get the researchers in 3 different rooms, you get these big Post-it notes, and then you have the community broken out. You get 1, 2, 3, and you break out, okay, into these different rooms. And you debate the pros and the cons of that question. And then you rotate after a set amount of time. I can tell you it was hard to get everybody to rotate. They were so engaged. They were talking so much. And they didn't want to break. I called time and they said, no, we're still going. We're still going, And I'd call time again and it was like, oh my goodness. But then at the end, we put up our Post-it notes when we all came back together again. And, we went through the pros and cons of the different, questions, and it ended up that we merged some ideas and we came to consensus. And it was just, I tell you, they loved it. And it was a fun idea. So thank you. World Cafe. All right, so strategy number 6. Now this is kind of a research-focused strategy here. And this is to collaboratively develop research questions. And once again, we had monthly meetings. In some of our other awards, we were meeting more frequently. But these monthly meetings seemed to work best. We had the community members share their expectations with us. So what they expected. We always asked them that. We had them, once again, with this research focus in mind, to share their challenges that they were experiencing and what needs were they having with regards to their diabetes management. In order for them to really open up, they had to feel it was safe. And you have to remember, now we're working in the Hispanic community here, and what was going on last year. You guys know what was going on last year, right? And I was so nervous that people were not going to come to these meetings, that it wasn't going to be safe. But they came out to those meetings anyway because it was safe, and we created a safe environment. And I felt privileged because, once again, we were doing research, and that's sometimes not always viewed as a safe activity. But they talked to us about what was going on with their ability to get health care, and sometimes the quality of that health care. We were able to get to consensus between what they expected us to give them and also what the research opportunities were out there. So sometimes, they would want certain things, and Brian and I would have to look at them and say, this research has already been done. So you may want that. We can tell you what the research shows, but we can't do that study. But here's what a research opportunity is out there that we could pursue. And then one of the more interesting things, and I know probably some of you have worked with the research or with different communities, when you're talking about doing research designs, that understanding of why would not everybody in the research study get the intervention? Yeah, that's a real foreign concept. And so we had some hurdles with trying to explain what a control and an intervention group is and why you would do that. And we had to lean on Jeanette to help us, over and over again explain that concept. And here, Jeanette, we gave it to her, and she went after it. I'm trying to move away from that microphone there. I don't know how to shut that off. At any rate, so she would help us reinforce some of these ideas. So now, in terms of a people focus, strategy number 7, you do need to be flexible, listen to everyone's input, and reach consensus. And a rule of thumb is, be non-judgmental. Did my mic just go off? It's going, okay. And sharing of personal life experiences, and this can lead to bonding and trust. And, when people do feel like they can speak from the heart, there is this trust that can develop. Community members did open up and they shared their thoughts. This was really invaluable. I really feel like Brian and I walked away from this understanding what made a difference for them. And we learned a lot about the culture, but also what could drive those research interventions that could make a difference. And it really broke the paradigm where the researchers were viewed as distant individuals, and we became more a part of this community, which was a neat feeling to be accepted, because I'm embarrassed to say I don't speak Spanish, but they accepted me anyway. I wish I spoke Spanish. I made sure my children did. But the community really sensed that we were committed. They valued our skills, they valued our time, our flexibility, and they valued our commitment. And, here's just a picture, working together, and just some of the individuals. Now, strategy number 8 is understand, embrace, and display cultural humility. Now, I just told you a really difficult thing, which is I don't speak Spanish. Oh, how I wish I did. But, you do need to learn and understand the community's problems. And in order to do that, you've got to sometimes be very patient as a researcher and to really listen. And sometimes, like I said, that can be hard. It could be because, you're filled with all the science, you know what works, and you know what works in your culture. And so, we listened, Brian and I were listening to homeopathic remedies, sometimes that seemed very odd to us, but we listened. And we listened to the fear of taking Western medicine. We listened to how these individuals didn't have, they trusted people that were a neighbor more than they would trust a provider, a healthcare provider, a doctor, a nurse practitioner in their community. So if the medical doctor said, you need to start metformin, and a neighbor said, don't go near that medicine, they would trust their neighbor more than they would that medical doctor. And, just once again, keeping your mouth shut and listening. We listened to stories about poor provider-patient communication. And, once again, this is a big cultural difference. So a patient nods their head politely when given instructions they do not understand. Now, being a provider, in my world, if I don't understand something, I just look at them and go, what? Tell me, I don't get that. I would never just kind of go, uh-huh, sure. I would just look at them and say, I don't get that. But there's so much respect that somebody in a position of authority, they'll just nod their head and say yes, but they don't understand it, they don't get it, they're not going to do it. So we learned a lot, we listened. And did you want to say something here about cultural humility?
Can you hear me? Yes, I can talk while she's changing the microphone. What the Dr. Allen was saying, it was very true, because at the beginning they want to call her Dr. Allen, Dr. Nancy, and she was saying, please call me Nancy, and they feel uncomfortable. And then I explained to her, if they call you Dr. Nancy, you'll have to let them, because in our culture, doctors are authority. It's a lot of respect, and they are not going to feel comfortable to tell you Nancy only. And she was agree, and people start feeling comfortable about it. When we decide to use the concept cultural humility, a lot of you, maybe you know about the concept of cultural competency, but no other culture is better than another one, right? We know that. It is impossible that we know everything about one culture. It's impossible to put in a box all the people and say, oh, they are Hispanic, because we are Hispanic, but we're so different. It depends on the country, where they come from. We are individually, we are very different. And that's why we adopt the concepts of cultural humility, because that give us the chance to expand our knowledge, to learn from each individual, to treat them appropriately to the, sorry. Go ahead. Yeah, okay. Thank you. Yeah, because that gives us a space to learn more about them. And it is impossible to know everything about one culture, but when you feel humble, you use humility to say, okay, I don't know everything about you. Can you teach me about your culture? And each one is different. And that's why we adopt that concept about cultural humility, because in Hispanic community, we like to talk a lot. And that was one of the things with research, because research want to go to the point, right? With this. And they say, just give it the time, because they want to go around and tell you stories and to go to the point, right? We like to hug. We like to be warm. And sometimes people feel intimidated with research, because they think that research are cold people that are over there at the very high point. And I said, you just have to open to them and give it the time to talk, asking honest questions. And as a result of everything, every strategy that you're seeing here, now in the group, they love them. Brian and Nancy, they love them. They miss them when they are not there, and because they feel comfortable to go to them and ask questions that they are not willing to talk to their principal doctors. Now they go with them first, and when they feel empowered by them, they can go to the doctor and say, oh, I know this. Can you please help me with this or that, or medicine or something like that? That's why we adopt that the cultural humility, and that is open the doors for a lot of experience for them and for the community.
Isn't she wonderful?
Oh, I continue with the strategy number 9. Okay, we continue building trusting relationship. As I said, now they love them, they miss them. But one of the things that we want to do is make sure that the group that we have right now, they can be self-efficient. They can be independent, because at some point we're not going to be with them. And we want them to empower them, that they can go outside and ask for their own health. They, give the power of their own health, go to the doctor and say what they need. And in order to do all these kind of things in the group, we empower them to share their talents. We empower them to share the knowledge, because in the group there is a lot of knowledge. And for example, in this picture, there is one of the participant in the group. She knows about nutrition, and she came and teach the other group about that. We give them the opportunity, and as you can see, they are gathering, they sharing experience. When they get together, they talk about medicine, they talk about frustration, they talk about how when they go to the doctor, what the doctor said or why they didn't say. We have a lot of people that has experience with diabetes, as Maria, and she share her knowledge with all the group. And that's what we want, individuals that are independent, no codependent of us, because they are the doctors and they are attached to them, that they cannot do anything by themselves. We don't want that. We want to provide that power to them and be confident that they can go outside and ask for their own health to the doctor. With this strategy number 10, we were talking about events, health fairs, festivals, everything, because it's an open door for you to go to the community, for the community to get used to your face, to know about you, to start building that trust relationship with the community. We have some pictures over here from festivals and health fairs. And as you see in the picture on the right, there is Dr. Brian, Dr. Allen, and the other researchers. And it was a good experience because, there's a barrier, big barrier with the language, right? And they are afraid to go with them because they don't know how to communicate. But there is one language that is universal. And when they see the love in their eyes, when they see the willingness to help, and there is always a way, And when they are at the health fairs, people just come, and we're trying to have someone that speaks Spanish there all the time to help them, to make that connection. And that's the way people get used to the research and trying to break that circle of not trusting or misunderstanding. And it was very good results with this. It was a strategic that is very successful because, as I said, now they are part of the community. They love them. They just adopt them. That's what I always said.
Okay, so now we're going to get down to some of the nitty-gritty. If you've not done this kind of research, here's some just nuts and bolts. So budgeting for community members. When you have a co-leader, which Pakora, they required that you have a community co-leader. Well, how do you pay them? So Pakora wanted us to pay Jeanette as a researcher. So she was paid as a consultant at a researcher rate. We hired her as a consultant for 20 hours per month. The community advisory board members were paid also one meeting per month, and they were given $50 per month in gift cards. The executive board members were budgeted 4 to 6% of their time, and the non-budgeted members were given $50 per month in gift cards. So, for example, we had Edwin Espinel from the public health department who sometimes would come to our executive board member meetings, and he'd be paid for that. Now, Pakora's influence on research, well, Pakora does things different because now you're getting all this feedback from your community advisory board, and your grants now read differently. So this was a study, this was a Pakora call that we responded to. And the title of this grant was, this letter of intent was a comparative effectiveness study of training models for community health workers to improve outcomes in Hispanics with type 2 diabetes. And just look at how the grant, the application starts. They call them awards. I try to tailor my language and sometimes I fail. The guiding scenario, Yolanda, and this is a true story, by the way. A 59-year-old Hispanic factory worker with type 2 diabetes was told by her doctor to take medicine, diet, exercise, monitor her blood sugars, and lose weight. Because of her cultural upbringing to respect authority, she nodded. Who could she trust to teach her in a way she understood and that respected her cultural? So it's a specific aim. The concerns of Yolanda, a patient member of our Hispanic Community Advisory Board, who participated in our monthly meetings supported by Pakora Tier 1 through 3 awards, could best be addressed by a Hispanic community health worker. And then I go on to define a community health worker. But you can see that just the introduction to the whole grant was a guiding scenario that was derived from the work with the Community Advisory Board. And then, you know, it was completely infused by the work with this community. So our continued work, can you just tell them quickly about, you know,
What we're doing right now?
Yeah, what we're doing.
Okay. Right now, the poster that you see on the right side is the Tomando Control de su Salud, is taking control of your health. Is a class, 6 weeks class that we're providing right now for the group that we have. What is the name of the group?
The Community Advisory Board?
The advisory group, yes. They are taking this class, and after this class, we're going to train a few of them as instructors. Thank you, as instructor. And now, after that, they're going to start doing the same class in the community, in diverse, in different places outside in the area, Salt Lake area. That's one of the goals. They are feeling very empowered because now they're receiving education, but they're going to be certified and they're going to go outside and do the same thing that they receive. Now they're going to give. And that's a way to empower them. We have an attendance right now of 25 people to the class. And I think probably we're going to have like 10 trainers in about 2 months. For summer, they're going to be ready to do the classes outside in the community. And it's a need because there's not much classes in Spanish for people with diabetes type 2. That's the goal that we have. We are working right now.
Yeah, so it was kind of amazing, you know, that the University of Utah holds these classes. The area on aging agency, well, I can never say that. At any rate, these different organizations throughout Salt Lake, they hold these classes and they don't have any Spanish community leaders that can teach. And so leave it to Jeanette. Boy, she gets them out there to do it. But here was just, we're out there, we've been doing, this is a TV spot that we did, educating the community about diabetes. And now Jeanette's just going to tell you a few patient stories.
Yeah, this is an activity. We always trying to give activities to the group where they can share their experience. This precisely is an activity to setting goals, and we're trying to connect something that they remind all the time. We use for this toilet paper. And it was funny because everybody said, what is that? And, you know, we have the connection now. Every time they say, oh, you know, every time I'm going to the restaurant, I remember that I have to work on my goals. And that was the point, you know, trying to connect something that remind them that they have to keep working on their goals, not because they have a commitment to us, but to themselves. Because we provide the education, we provide the resources, but at the end is their decision if they're going to do it or not. And we always talk about this, give the power back to them, because we are not forcing them. We want to empower them to take control of their own health. We have, in this class, we share stories about how the technology that Dr. Gibson provide help them. We have a young lady that she is like 32, that she used the monitor, the glucose monitor, for a week, for 24 hours. And that helped her a lot to understand their body, because diabetes is individual. It's not the same for two persons. And they didn't know that. they thought about, she has diabetes, I can do the same thing as she is doing. And it's not like that. And this technology helped her to understand each part of their body, how they react to the food. And, as a result of that intervention, she lost about 40 pounds just for knowing their body and how she reacts to each food that she put in her body. And it was a very successful story about that. She cried because she has a little boy, and now she feels healthy. Now she's doing exercise. She understands her body. She learns to love her body because she was overweight, and with diabetes, she has in this stage when she didn't like herself. But now with the technology that they provide and the education, she feels healthy, doing exercise, and feel plenty. Yeah.
That was a real-time continuous glucose monitor that we had a lot of the members, and we've got a poster out there talking about this, but where, and so it was providing continuous feedback of their glucose. And many of our members in the Community Advisory Board didn't have any experience with technology. So, we did another trial and had them experience this and then interviewed them about it. But this was, it was so touching. I mean, she came and she just cried, and it really motivated her. But we had many, many other stories that were shared from their experiences. So the academic achievements. Now, Pakora is a little bit different. So they want you to disseminate your research in many different ways. And what they consider dissemination is different. So they wanted me to disseminate it within, my local place, in the College of Nursing, and obviously Brian and his department as well. They wanted us to disseminate it within the Hispanic community. So we were on TV. We were in the Hispanic newspapers. We were at the health fairs. We also, of course, went into the academic world through poster presentations, oral presentations, and we're now moving into writing our manuscripts from this work. Brian and I are working on a grant that we'll be submitting in June. That's going to be derived from a lot of this work. So it's kind of the way Pakora wants you to put out your work and disseminate is more broad than just kind of that traditional academic dissemination. So at this time, we thought we would leave plenty of time to open it up for questions. Hopefully we've got lots.
First of all, the kind of work that's being done at the community level, that's wonderful, excellent. The only thing I don't know is, now this is Hispanic community centric. Mm-hmm. Is there such organizations that you are collaborating with in the Valley? Polynesian groups, American Indian groups, and some other minorities.
Yes.
And
come to the next session.
well, yeah.
So yeah, the comment is come to the next session, and a lot of those groups are represented and will be presenting their experiences.
Okay.
Yes.
And then the only other thing is, how do we then leverage findings that you have with others, so best practices and so on?
So that's a great question. And so the University of Utah, through the CCTS, has a core. And in this core, they call it the Community Faces of Utah. And they have representatives from each of those groups. And so if you want to undertake research, they have the leaders, like I said, from each of those groups, and you can go to them. They will, you can present your research idea. They will advise you. They'll go back to their communities And they'll ask their communities about your research idea, then they'll come back to you and they'll advise you on your research ideas. So there is how do I say, the university does have a mechanism for you to do that through our CCTS. You know, so there's a broad mechanism here.
Thank you.
Can I make one addition to that?
Yes.
A plug. Lisa and her group has created a best practices notebook about these kind of studies.
Oh, great.
That's, oh, sorry. So that, I don't know where that's published, Louisa, you can comment.
We're in the final revisions, and people who come to the next session in this room will hear about it.
So you'll go to the next session if you're interested in that. You can find out more about that best practice.
Thank you, Brian.
Hi, thank you so much for your presentation. It's very helpful for us who are doing community engaged research. You mentioned that your agenda was in English and Spanish, but can you talk about, did you conduct the meetings in Spanish or English, and how did you navigate that with having board members that may have been more comfortable with one language rather than the other?
Yeah. Oh, can you hear me? Yeah.
Yeah.
It was very interesting because we have the agenda in English, and then research language is very complicated. You know, the only people that can understand it are researchers. And yeah. And then I said, oh, Nancy, I said, this is so complicated. Let me, trying to level down a little bit the language, put it in Spanish in a way they can understand. I was the kind of the mediators. Our meetings are conducted in Spanish. A lot of the members in the group, they understand English. Another one are bilingual. But for the ones that don't speak English, we do it in English. I translate everything that she is saying, that she is sharing. We're trying to have that, the flow in the group, that everyone feel comfortable about their own language, and it's okay if you don't speak English. We have that translation for you. And the agenda, as I said, we presented in Spanish and in English, and trying to make sense of both in a literacy a little bit down, that we can go both in a point where we can understand, but they have what they need, but the community feel that they can give something as well. And it was very interesting, our groups, because at the beginning, it was like, I don't understand what you're saying. And another thing that was important, I think, I always remark in the group, that this is a long time term, this is not something that is gonna happen tomorrow or next week or next month, because we tend to be impatient. We want to resolve right away and say, this group is different. We have to be patient because this question is going to take us time. I try to remark every meeting, and they understand. They understand the process. It's been 4 years already, 3 years, yeah. But they enjoying every meeting. They gathering together. It's like a small family. And now they get used to the process that we have to be patient. But our meeting is in Spanish and translation with English.
It's a great question.
I'll just ask a question, I think, structurally, and I'd invite any of the researchers or community members to answer. What I hear about this is that this takes time, relationship building, how many grant proposals include attending community events. So it just makes me think we need to challenge our research communities, our grantors, or find partners that really make this work as a viable continual stream. So anybody have comments on, solutions for, Pakora, I guess, is funding this kind of thing. Are there other places we're seeing funding to do the kind of deep building that needs to be done? And I'll invite Luisa or Brian or anyone else to answer as well.
So the question is there anybody else funding this, type of work? Okay, look at Louisa.
Yeah. So I think that the Utah Center for Clinical and Translational Science, with our collaboration and engagement team, building with Community Faces and other groups is building the long-term relationships that those of you who are researchers can come and tap into. So there's already relationships that have been built. And as Jeanette and Nancy have talked about, relationship building takes a long time, but that can shorten the amount of time it takes to start to build relationships. And then each of the communities and Community Faces of Utah has their networks that they can also reach out to. So that can help you shorten the time of building relationships. It still takes time, but it helps if there's an infrastructure there already.
Yes, yes.
And your project got started because we talked with Brian quite a few years ago.
Yes.
And helped him get started down this whole path.
Yes.
That led to this wonderful series of grants and this whole project.
Right, right.
Hi, thank you for your talk. This is great. I had a question about the finding you had about the respect for physicians causing people to nod in agreement if they don't understand something. I find that a really interesting and concerning barrier to care, especially because patients often benefit when they are highly engaged in their own care and willing to advocate for themselves. So I'm wondering, have you thought about next steps with that as far as intervention and what level you would intervene at with the patients or providers and what we can do with that information?
That's a great question. So, Jeanette can probably speak to this, but what we heard over and over again is the importance of having kind of a health coach that and a community health worker that can kind of, engage with them. So it's important for somebody to be there that understands them and understands their culture and can give them that social support and that peer support. And that was kind of like, through all that listening, we understood pretty clearly that, you can have the best medical plan ever. And you know what? It won't work. So what really is going to work is, trying to get that whole buy-in, and you're going to have somebody who can provide that social support. So we've got 5 minutes left. I think you were up next.
Also, I want to high praise and thanks for your research and your presentation. It was fantastic. I can't resist an opportunity to thank you for all of your work you've done with the community health worker movement in the state of Utah. It's just been fantastic. Many of you don't know that this fine person has led this group, conferences where 350 community health workers come, receive training, education, empowerment. Your work has just been phenomenal, and the difference you've made in the health of Utah is fantastic. So thank you so much for everything you've done.
That's right.
Yeah, I feel the same way. And I had a question, and now it's gone. So I'm just going to leave it at that. Thank you.
I just wanted to ask, we have a community care council in our community being run through our clinic, and we're working on getting a lot of cultural diversity, so that comes with its own challenges. But how long did it take you to get to a point where you felt like you had that that trust to be able to kind of move into actually making some true changes? Like we've just barely decided on our topic that we're going to battle this year, which is patient empowerment, actually, and helping our patients know like the right questions to ask and things like that, and trying to help them connect better with their providers. But how long did it take you to get to that point? Because we've spent 6 months just kind of getting to know each other and things like that, and getting to that point. So how was it for you?
One of the things that I do in the group is I ask them first to don't say anything, just listen. And when I go to them and say, this is your time. You have to talk, because if you don't talk, we cannot make changes. And we empower them, saying, talk, be honest, be sincere. Just let them know what you need to know. And trying to break that circle. And at the beginning, it was hard because they feel that they're going to offend them. And I said, no, just say it. They are not going to say anything. They're going to listen to you. And they feel, it takes us a few sessions, but at the end, once the one do the breaking the circle, the other ones are going to follow up. And they start telling them about the challenges, how they feel, their frustration. And when they listen and they didn't say anything because they did not lecture them, they feel comfortable to let them know more about that. Just listen, sit down and listen. What is your need? What do you feel? What do you expect from us? And that is important because, in the health system, we know for the group that they said they don't pay attention to me. I'm trying to tell them, but as I said, our culture, we talk a lot. We have to go all around to tell the one thing. And, when you go to the doctor, all around you stay there because you never got to the point and your time is over. And that's what happened. Yes, and then that's what I said. Just you need to talk right now, because this is your time. Please, just do it.
So
And
it
they
took
do it.
somebody like that. She told us there was a time to listen, and then it took her telling the people in the group, now talk. See, so it was her influence. So I mean, I would say we were about, I don't know, they were pretty open pretty quick, maybe about 3 months in.
I advocate for the community health workers. If you want to do something, hire a community health worker because she is going to help you to achieve the things that you want to achieve with your groups, with your intervention, with your research. And you have to give something back to the community because we cannot use the community and, we use your information and that's it. No, you have to give something back because otherwise every work that we're doing to break that circle of not trusting is going to fail. Yeah, just don't use the community. Give something back.
All right, you guys, thank you for sharing all the insight. Good work.